Thank you so much, and I want to thank the panel for being here today. I was caught up in other duties, so I was late, but I was listening to a lot of your testimony before I arrived. And I was intrigued, Dr. Brown Friday, by some of your testimony that talked about diabetes, the onset of diabetes starting at younger ages, and not juvenile diabetes, but type 2 diabetes. And do you attribute that to the junk foods and stuff that President Nygren, for example, has talked about? What do we attribute that?
Well, first I want to make a correction. I am not a doctor.
Okay.
I am a registered nurse by profession.
That's good.
I'm very proud to be one. So in terms of type 2 diabetes starting at younger ages, this is something that's been a concern for the medical community and the American Diabetes Association for quite a while. And I definitely agree with Dr. Nygren that the availability of healthy foods and having closer to availability, fast foods, not just for Dr. Nygren, it's the big gas stations. And for me, who works in the Bronx, it's access to McDonald's and, I'm sorry for you, and other fast food companies where it's just higher fat in the foods, and younger people are not, like I said, once you're introduced at a younger age to healthier foods, then the more likely you are to have those foods when you're older.
So, Mrs. Brown, it's sort of counterintuitive for us to be cutting, fruits and vegetables from the WIC formulary, as an example, and upping things like cheese as part of the formulary for WIC. It just doesn't make any sense if we are trying to curb the cost of diabetes to be cutting fruits and vegetables out of WIC. That's my statement. I won't make you say it. I am intrigued by the disproportionate presence of diabetes in Black, Native Americans, and Latino communities. And so I guess, Dr. Herman, there's no sort of genetic proof that these folks are disproportionately susceptible to enduring diabetes. So what would you say how do you explain the disproportionate onset of diabetes in these populations?
I think that's really an excellent question, and I don't know the answer to that question. I will say there are many investigators out there looking at that question specifically. What we do know is that obesity and diabetes in all populations is an interaction between genetic background and environmental exposure, and that includes diet and exercise and all sorts of things. And so if there is an increase in prevalence of obesity and diabetes in one population, it is some combination of a change in their environment, interacting with a change with their genetics, which has not changed over decades, that's producing that outcome. And it takes intensive research to identify within specific populations what those specific factors are. But there are many scientists and physicians out there searching for those answers within specific populations at this point.
Well, thank you so much. Your testimony, I think Mrs. Brown Friday made the testimony that 85% of people who have diabetes are obese, are overweight. And this is one of the reasons that I'm so happy that I have reintroduced a bill called the Treatment and Reduce Obesity Act. I think that it'll give us some great results with regard to stemming one of the causes or one of the present features of diabetes. I wanted to ask President Nygren, the Menominee and Oneida nations in my state of Wisconsin have taken on a culturally relevant project to use sort of native foods to stem the tide of diabetes. Can you describe what you all are doing in the Navajo Nation to include culturally relevant foods?
Congresswoman, thank you for that question. I'm very happy to hear that our other tribal communities are doing that. And on behalf of the Navajo Nation, one of the things we're doing is walking and running. That's been very a part of our culture. And at the same time, introducing them to foods such as fruits and vegetables at all of our events, along with like almonds and nuts and things like that, that really help and promote a healthy lifestyle. Because one of the things we've always done is we take the IHS best practices and we try to focus on one of them for the year so that we can implement and educate our people on that. So we really have taken an approach where we invite the people out to the events, and then they do a walk, a run, or we educate them on foods. But as far as farming, we're really trying to reintroduce farming because Navajo people have been farmers for a very long time. It's just that it's a lot easier to drive a couple hundred miles and get a bag of groceries than to actually do the work and to produce healthy food. So, but that's something that we're really working on, Congresswoman. Thank you.
And my time is waning, so I just want to get another question in with Dr. Brown Friday. I didn't understand why the continuous glucose monitor is not available to more low-income people. Is that something that is not authorized by Medicare, or what are the dynamics in terms of getting these continuous glucose monitors available to low-income people?
Unfortunately, I am not an expert in Medicare, and I can't. And so, what I would have to say is that, in general, what I've heard from patients is that their insurance will not cover the cost of utilizing the continuous glucose monitor if their blood sugars are not at a certain range, or if they are not taking a certain number of injectable medications. And so, therefore, those are the things that are regulating the availability.
Bureaucracy is stopping us from saving money. Okay, I'll yield back to you, Mr. Chair.
Thank you, Ms.